display the web series slides to begin with, so we can start with the introductions. Right. So maybe we just give everybody a couple of minutes, if you don't mind, because people are joining as we speak.
Definitely.
Right. Good evening, everybody. Am I audible?
Yes, sir.
Right. So with the permission of the speaker and the chair, we can start the proceedings of the evening. Some people have already joined in, so we'll start with the introductions. Dr. Sarkar, Dr. Satish, can we start?
Yes, sir. Please, sir. Yes, sir. Please.
Right. Good evening, everybody, and welcome back again to the latest edition of the DY Patil Postgraduate Lecture Series. We are back with a bang with a very good talk today on one of the oldest yet one of the most confusing drugs in psychiatry, because it's as complex as it is old, and it went off and came back with a renaissance, and I'm sure Dr. Suhas Satish will inform us a little more about it. But we are grateful that Dr. Satish and Dr. Sarkar could take the time out to be with us today and be a part of this postgraduate training program, which we have been running for close to 10 years now. So every month religiously. All these lectures are available on the website of the PG series, and for perpetuity, all the slide decks as well as the videos are available on the YouTube channel, which can be accessed from the website. So not just people who attend live, but even otherwise, you may be able to access this meeting and be able to continue to learn from whatever wisdom is shared by our esteemed speakers. We welcome Dr. Suhas Satish and Dr. Deepan Sarkar. I have the honor of introducing Dr. Deepan, who is with us today as a chairperson for this session. He's a consultant psychiatrist, and he's at the Modern Psychiatric Hospital at Agartala at Tripura. He has a fellowship in psychosexual disorder. He's a nodal officer in addiction treatment facility at Agartala. He's an EC member and an IPS zonal representative of the East Zone. He's been a president of the East Zone Tripura State Branch. He's an author of different books, especially a book called Different Strokes. His areas of interest are addiction, medicine, psychosexual disorders. Welcome, Dr. Deepan Sarkar, and I would request you to introduce to us the speaker, Dr. Suhas Satish, and start with the proceedings of the day. I'll come back towards the end of the program to just give my vote of thanks. Over to you, Dr. Sarkar.
Thank you. Thank you very much, sir. First of all, I would like to thank D.I. Patil Medical College and the University to give me a call for this for moderating this session. So once again, I thank you very much, sir. And Dr. Rashmin, he actually communicated me around a few months earlier, and I'm very much thankful to him and other senior faculty members who are present here and other PG students, those who are here. Actually, as we know that this Clozapine is maybe the first atypical antipsychotic, and if you see the evolution of this molecule actually since beginning from its first synthesis in the 1958, we have seen that it had very much turmoil in regards to drug interaction, and the effect inside the body is in inverse of that one side effect profile and so many things. Definitely, it is one of the toughest molecule because even now also there are many psychiatrists that they think twice to write Clozapine. So I think for the PG students, those who are here, it will be a very much effective interaction and the lecture. I think Dr. Suhas Satish sir, he will give in his lecture, and because this is one of the like you can say the Brahmastra, what I feel among the antipsychotics, that it can be applied. And what are the points when we will start this molecule, and what are the preliminary things we need to see? And there are many things. I think I'm sure that Dr. Suhas Satish in his speech, in his lecture, will clear all the confusions, and so that we can give the best molecule those who need this molecule in the field of psychiatry. So this is a very much a good topic chosen by the authority and the medical college. I think the session will be very much effective one. So while coming to the speaker, I think he is very much well known by Pan India. It doesn't need actually a different introduction, but it is customary for me to introduce him. Today's speaker is Dr. Suhas Satish. He's in NIMHANS, Bangalore. And as you can see that he was the awardee of Early Career Fellowship Award in 2019 and NIMHANS Silver Jubilee Award. He was the best student in the psychiatry in 2018. And he has actually various fields where he's working actively that I think if we start, we cannot finish it. So I'm skipping this part. And he has many publications throughout his, till now he has done many publications, and I think in future also more will be there. And his areas of interest is schizophrenia, definitely Clozapine, one of the molecule you can say that any doubt, any question, it can be cleared by him. Even I hope that I will also learn many things from him. And his interests are only not only this chapter, in other areas of psychiatry, neuromodulation, therapeutic drug monitoring, and AI also, that is pretty much upcoming topic right now, and definitely the academic psychiatry. So without losing much time, I'll request Dr. Suhas Satish to please start his lecture. Please, sir.
Thank you, sir. Thank you for that kind introduction, and thank you to the DY Patil University and Professor Rashmin Kulera for inviting me to deliver this particular talk. And as Dr. Sakar very aptly highlighted, this was planned well in advance, and this particular topic is something that is close to our heart. And the reason is that it is perhaps one of the most important drugs in the field of psychiatry, and it is important and pertinent that we speak about it to our psychiatry postgraduates. May I request the moderator to kindly permit me to share my screen? Yeah, thank you. I hope that my slides are visible. So today's class is for the coming, say, about 45 minutes to 50 minutes. We will be talking a bit about tackling this toughest drug in psychiatry. Now, I use the word tackle with a lot of thought, because tackle is more of a wrestling term. It's more of a sports term, wherein you will have to inevitably counter the plans that the opposition have made, in which you are actually likely to encounter, and be ready with your counter plans when managing the opposition in the field of sports. Now, clozapine is one such molecule which we use in the field of psychiatry, especially in case of resistant schizophrenia. And therefore, whenever we use this particular molecule, we have to understand its importance, the correct way in which we use them, and also be aware of the various challenges that it poses for its use and how to counter all of these things. So I'll be covering some of these aspects in my presentation. But of course, as Professor Collier pointed out, it is perhaps important that I start a bit about clozapine itself before I head into the tackling part. It is a unique antipsychotic because way back in the 1960s and the late 1950s even, when clozapine was discovered, it was found to have D1, D2, and D4 antagonism, but with very low D2 affinity. So it's atypical in that sense and a unique antipsychotic in that sense, because compared to the traditional antipsychotics like haloperidol, chlorpromazine, it really did not produce enough neuroleptization. And therefore, people actually use the word atypical antipsychotic for clozapine when it was discovered. It also has a unique profile in the form of 5-HT2A inverse agonism, which we often partly erroneously attribute as antagonism, and a little bit more on that and what role it plays in its use in treatment of psychotic disorders later. Chemically, it's a dibenzodiazepine, and it is very similar in its molecular structure and in its functions and in its adverse effects to the other antipsychotic that we use commonly called as olanzapine, which we are all aware of. Now, with respect to the road to clozapine, in about 1958, it was the Vander AG pharmaceutical company, which was actually a Swiss pharmaceutical company, that discovered this unique molecule called as HF1854. And its initial claim to fame was not particularly for schizophrenia. It was known to have multi-receptor activity and a low EPS. And so it, in essence, countered Janssen's neuroleptic dogma. Janssen's neuroleptic dogma was that Janssen, not the pharmaceutical company, but the scientist, after whom the pharmaceutical company is named, the scientist, he had actually laid down a set of guidelines wherein he had said, for an antipsychotic to be effective, it has to lead to EPS. He said any drug that doesn't lead to EPS really cannot be used in psychosis. So in that sense, it was considered as an atypical or a defective antipsychotic. But in the early 1960s, there were open label clinical trials that were conducted in which clozapine was used in doses at around 160 milligrams TID in about 19 to 20 patients, and its efficacy was documented in schizophrenia. In the early 1960s, concurrently, it was used across Europe for many patients who were unresponsive or either who did not respond, but or who were intolerant to the other typical antipsychotics. And people had started noting that these patients who are actually given this molecule seem to respond to both the positive symptoms, but more importantly, to the negative symptom dimensions as well. So that fueled intensity of interest in this particular molecule. But then came the famous case series from Finland, wherein there was a spate of agranulocytosis in patients who were treated with clozapine. And most importantly, this particular study, which was reported by Amsler, and which highlighted that people actually developed agranulocytosis, fueled a lot of concerns among treating clinicians, and which essentially took clozapine off the market. What actually it resulted in was a sudden disappearance of clozapine from the market. Then there was a lot many years in the 70s and the early 1980s wherein clozapine trials were suspended, its use was suspended, and patients who were already being treated on clozapine because its use was suspended and it was not available, they started experiencing relapses. There was certain pushback from the German psychiatrists who started saying, hey, wait a minute, it actually seems to work fine. And although there is a reported incidence of agranulocytosis, is it something that could be used with caution or for compassionate use in patients who are either intolerant to antipsychotics or in patients whom traditional antipsychotics are not working? So finally, there was a highly monitored sort of a research use or a compassionate use that was granted, and it was actually being used in select populations only, with very minimal clinical data coming out in published literature. Simultaneously, something else was parallelly happening. The dopamine theory of schizophrenia was evolving. Prior to that, the neurobiology of schizophrenia was very less known. We knew schizophrenia as schizophrenias, multiple symptom dimensions were reported. But when the dopamine theory of schizophrenia evolved, people actually started to understand that there are symptom dimensions and there are certain dopamine neurocircuitry abnormalities that are important for positive symptoms and certain other neurocircuitry abnormalities that are important for other symptom dimensions. When that evolved, people started showing more and more interest, or they started going back to perhaps the important molecule that is clozapine. Before Kane could come and set the record straight for all of us, what was happening was there was anecdotal signals in the form of case reports here and there, clinical presentations here and there, wherein people actually highlighted the importance of clozapine, especially in resistant patients. But there was no robust controlled evidence that happened. Opportunistically, at that point of time, three things happened, which perhaps are very, very important historically, which led to the re-emergence of clozapine like phoenix from the ashes. The first thing that happened was that Sandoz took over the company Vander AG, and Sandoz started developing a keen interest in repurposing some of the older molecules that were discarded. NIMH actually started setting down guidelines for ethical research, and they were actually willing to take a high stakes bet on some promising molecules. And Kane and colleagues simultaneously were also interested in examining clozapine and whether it actually has a superior efficacy in resistant schizophrenia. Now, when all of these three things came together, Sandoz's interest in looking at clozapine, the NIMH and its role in saying that I will lay down the guidelines for ethical research, and Kane and colleagues who all came together and said that, well, we could look at it in a very robust scientific manner, it led to the famous 1988 study on the role of clozapine for resistant schizophrenia. This was published in the Archives of General Psychiatry, which is basically the former version of the current JAMA Psychiatry. And in the Archives of General Psychiatry, Kane published this seminal article in which they looked at a double-blind comparison of clozapine with chlorpromazine and established the superiority of clozapine in the treatment of resistant schizophrenia. But when we read in between the lines, it becomes very important to understand the burden of the task that Kane was entrusted with. Because when he was set out to do this experiment, now he had to do very many things because it was a high stakes experiment. He had to choose a population in which treatment resistance is conclusively established. He had to choose a population who were still severe enough and needed treatment for schizophrenia, he had to choose a population in which positive symptom dimensions were prominent. And then he had to also ensure somehow that adherence was taken care of, because non-adherence was a major issue as it is now, and it was the same issue there as well. And so Kane somehow had to come up with an robust methodology to conduct this particular study. And therein, it was a high stakes experiment wherein he had to define and operationalize the resistant schizophrenia as objectively as possible. He had to design an ethical RCT wherein only the truly resistant patients were coming in, and it was not just cherry picking of patients who could just come and show a response and falsely that one could claim that clozapine worked. He had to avoid a lot of heterogeneity in the sense that at that point of time, we knew schizophrenia as schizophrenias, and there were multiple variants of schizophrenias. And therefore, if there was a lot of variants of schizophrenias taken into consideration, the heterogeneity would mean that we cannot make meaningful interpretations of the clinical response. He needed to ensure that the placebo effects were avoided, and he also needed to manage the safety fears around the agranulocytosis. So with this heavy burden, Kane and colleagues actually came up with what we operationalize now as the Keynes criteria. Originally, it was different than what we used in the modified Keynes criteria, but when he operationalized this particular criteria, because of all the important points that I highlighted in the previous slides, he had to initially say there has to be a past established treatment failure. So then they said that there has to be a failed response to 3 antipsychotic trials. Out of these 3 antipsychotic failed trials, at least 2 have to be from different chemical classes. And at that point of time, dose adequacy was established in the form of chlorpromazine equivalents. And it was not 600, but rather 1000 milligrams per day chlorpromazine equivalents, which was considered as the benchmark when we said a person had received an adequate trial. And not only should the person have received this 1000 milligrams per day equivalent of chlorpromazine, but the duration of the trial had to be for about 6 weeks or more. Now, in addition to this, they needed to ensure that they were ruling out the cohort of patients who were acutely psychotic, because there was a lot of data coming from the IPSS and the other similar studies from world over, which said that people with acute schizophrenia, brief psychotic states, tend to have a better prognosis. ATPDs tend to have a better prognosis. So therefore, he put in the criteria that this had to have a long-term course, that there has to be no period of good functioning in the past 5 years. Then he came up with what is called as a cross-sectional symptom severity criteria, wherein he said that these patients should be sufficiently sick because we are giving a molecule like clozapine. So the brief psychiatric rating scale total score should be more than 45. And among the core symptom dimensions, they should score equal to or more than 4 on at least 2 out of the 4 core BPRS symptom dimensions. And these, if you look at it, are conceptual disorganization, suspiciousness, hallucinatory behavior, and unusual thought content, what we loosely now operationalize as the positive psychotic symptom dimension, which includes formal thought disorder as well. Then he also used a much more easier to apply and a standardized scale called as clinical global impression. And he chose patients who were more than moderately ill or more worse, like they could be severely ill or very severely ill, but they definitely had to be moderately ill. So now they had established historically that these people had not responded to many antipsychotic trials, at least 3 in the adequate dose and duration. He had also established that these people are actually sort of suffering from disorder severe enough to especially have core positive psychotic symptoms. And then one thing that was needed to be established was, what if they hadn't taken the medicines properly? Well, the doctor used to prescribe, but then what if they didn't take the medicine? So he also laid down a prospective element to the Kane criteria, wherein he said the patients would be receiving a prospective haloperidol trial, and they would receive up to around 60 milligrams per day, doses that is unheard of in the current day contemporary practice of use of haloperidol. But he also laid down that it could be the maximally tolerated haloperidol dose of at least greater than or equal to 20 milligrams per day, which is the maximum tolerated dose, daily dose that is prescribed in current literature for the use of haloperidol. Then he said, if after a 6-week haloperidol trial, people actually failed to achieve both a greater than 20% reduction in the BPRS score, and they did not actually achieve remission on the CGI severity, then they would be qualified for this particular trial. Now, this is the birth and this is the origin of the original Kane criteria. If you have now understood until now why the Kane criteria came into existence, what was the burden on Kane's shoulders, it would be very easy for all the postgraduates to remember this in the exam, isn't it? Because all you have to do is remember that people were very skeptical, they didn't want to use it, they had to choose only the worst cases, they had to also prospectively look at patients if they were severe enough, they had also to look at whether they were adherent to a prospective trial. If you remember these three things, Kane's criteria becomes a K. So clozapine thereafter became very famous because its superiority in resistant schizophrenia was very well established. And subsequently, there has been a lot of reported literature which has actually proved time and again that it continues to remain one of the best molecules for resistant schizophrenia. However, clozapine, despite being extensively studied during residency, wherein people read about all the clozapine adverse effects, pharmacodynamic actions, pharmacokinetic interactions, managing the adverse effects, clozapine augmentation strategy, it continues to be heavily underutilized in schizophrenia, not only in India, but world over as well. And it is in fact a much feared molecule, so much so that people have even published papers on it calling it as clozophobia. Hopefully, by the end of today's lecture, there will be less clozophobia. Residents would be more familiar with this wonderful molecule. They will get more confidence to use this molecule in an evidence-based manner so that they are aware of all the adverse effects and with risk evaluation mitigation strategies that their patients will benefit from the use of clozapine, especially in resistant schizophrenia states. So how do we actually optimize the use of clozapine? How do we actually tackle it? There are very many ways in which this has been recommended in public literature. However, I'm going to focus through this particular lecture only on the evidence-based practice approach so that through this outreach, all of you will be able to optimize the use of clozapine for your patient population. So when we say tackling clozapine adverse effects, we need to know that there are two categories of adverse effects that are seen. One category are the common adverse effects, which are seen very commonly in the population. And the other category are the serious adverse effects, which are not so common, but they could be potentially life-threatening. Common adverse effects include things like sedation, hypersalivation, constipation, hypotension, weight gain, tachycardia, and serious side effects include serious adverse events like agranulocytosis, seizures, orthostatic hypotension, myocarditis, and increased risk of sudden death, especially in patients who have dementia or related psychosis. In fact, there is FDA black box warnings for most of the serious side effects of clozapine. Let's go through them one by one. First, let's talk about constipation. Constipation is very prominent in clozapine, especially during the first 4 months, and it is usually one of the troublesome common side effects of clozapine that persists with time. The mechanism by which clozapine causes constipation includes muscarinic antagonism, weak antagonism at the 5-HT3 receptor, antihistaminergic propensity, and also its role in producing a sedentary lifestyle, which might have a contributory element from the primary negative symptoms as well. When constipation is seen in patients who are treated with clozapine, we can find it as commonly as every second or third patients whom we treat with clozapine, because the prevalence rates range from 30 to 60%. What we have to very importantly keep in mind is that the fatality rate of a resistant constipation, which goes into paralytic ileus, could be as high as 15 to 27%. Now, when I say the fatality rate of untreated paralytic ileus is 15 to 27%, you need to contrast that with the fatality rates of severe neutropenia, which is as low as 2.2 or 4.2%. The reason why I'm contrasting this is that we speak a lot about neutropenia when it comes to the clozapine adverse effects, but we rarely speak about the importance of paralytic ileus. So therefore, it is important to keep in mind that although constipation is a common side effect, if untreated, if undetected, and if the patient continues to not seek medical care, it could lead to a life-threatening emergency. We also have to keep in mind that clozapine, in addition to causing constipation, the mechanism of the constipation is such that it causes a slow transit constipation. which means to say that the time required for the processed food to actually traverse through the colon can range from 23 hours to as high as 100 hours. Therefore, you can find patients coming in saying that they haven't passed stools for as high as 4 days, 5 days, 6 days. At times, it is hard to believe, especially for young postgraduates who are studying psychiatry, that how can a patient not have passed stools? But that is very much possible. Another important statistic to know is that the median time duration between the onset of the clozapine initiation, clozapine causing constipation, to a ileus formation could be as high as 5 years, which means to say we can never really take our foot off the pedal in our vigilance about constipation when we use clozapine. So through this slide, I have shown that constipation is a common adverse effect. We need to keep asking about it with our patients. If untreated, it could lead to a high mortality rate, especially if it goes into paralytic ileus. And we need to be aware that paralytic ileus can happen 5 to 10 years also after the initiation of clozapine. So how do we actually detect clozapine-induced constipation? Apart from asking a generic question that are you passing stools regularly, which is in itself not good enough. So we use the Rome 4 criteria. Now, the Rome 4 criteria are originally used and recommended for use in opioid-induced constipation. It has been operationalized wherein 2 or more of the following symptoms are there. The magic number to remember over here is 25%. It's easy. Let us make this easy for you. We need to ask the patients, firstly, if there are straining for more than 25% of the defecations. Asking them that if you go to defecation for 4 times, do you strain more than once? Asking them that whether they are passing lumpy or hard stools. We use what is called as a Bristol stool form. There is also a pictograph. There is a pictures of the stool forms. We need to have that in our clozapine clinics or schizophrenia clinics so that we can show to the patients and ask them if they're passing lumpy or hard stools. And if they're passing lumpy hard stools more than 25% of the time, then that is another criteria. The third criteria is asking them that if they feel that the evacuation is incomplete in more than 25% of the time. The next criteria is asking them whether they have a sensation of an anorectal blockage more than 1/4 of the defecations. So in addition to having an incomplete evacuation, where they feel that there is an obstruction or a blockage. The last 2 criteria are asking them whether they use any sort of manual maneuvers or other maneuvers, assisted maneuvers, to facilitate a bowel transit, especially more than 25% of the time. You'd be surprised to know patients come up with innovative methods. I had a patient who complained that to pass stools, they had to put a device up their anus and actually relieve the stools because the constipation was that severe. And only if you ask will the patients speak about them, because they're very, very embarrassed to talk about it. So please, if there is one take-home message from today about constipation, it is this, that you need to ask about it in every visit to the patients who are treated with clozapine. The last criteria is, of course, if they're having fewer than 3 spontaneous bowel movements per week. And if the patient satisfies 2 or more of these criteria, it means they're suffering from clozapine-induced constipation. What do we do? Okay, we have detected a patient is having clozapine-induced constipation. What do we do about it? The first thing that we do is not rush to implicating clozapine alone. So we look at the other medicines that could be worsening the constipation. Are they concurrently on other anticholinergic medications or medications with anticholinergic propensity, like quetiapine, like trihexyphenidyl, if they are concurrently treated with another antipsychotic? We then, having ruled out the other causes for the constipation, look at whether we can actually instill lifestyle modifications, wherein we ask them to increase their food intake of raw leafy vegetables. We also ask them to consume water. We also ask them not to eat foods that are rich in maida. And we also ask them to exercise regularly and have a regular bubble time after a morning exercise routine wherein they can go to pass their stools. If all of these lifestyle modifications fail, we can use measures such as giving an osmotic laxative like polyethylene glycol, which can be used in 17 grams once a day to twice a day. which we can also institute lactulose, the use of lactulose. Now we have to understand that lactulose is an osmotic laxative, which means to say it has to be used up to about 15 to 30 ml per day, and its use might have to be split during the daytime. It might have to be given in a thrice daily or a twice daily formulation. But a very important point about lactulose is it does not work for the relief of acute constipation, which means to say that if somebody already has not passed stools for 5 days, 3 days, you do not prescribe lactulose and send them away. The reason is that the onset of action of lactulose is 72 hours or more. So which means to say that another 3 days before the lactulose can have its effect. So therefore, under such exigent circumstances, we have to use stimulant laxatives like bisacodyl, which can be used 5 mg once a day to about 15 mg in split doses. We can also use secretagogues and the stimulants like prucalopride, which can improve the gut motility and help in the clearance of the constipation. We can also use cholinergic agonists 10 mg thrice a day, but these are not regularly used because of the fact that they can have certain rebound phenomenon associated with it, especially when we are already giving clozapine. We follow what is called as a Porirua protocol, wherein if none of the lifestyle measures have helped, and if the patient is not benefiting from some of the first line agents to treat the constipation, we then initiate Docusate 100 mg and Senna 16 milligrams at night. Mind you, both of them are available in India. And if after initiating them, 2 days of more of constipation is seen, then we increase the dose of Docusate to 200 mg and Senna to 32 mg per day. And if despite both of them, still there is constipation for 48 hours or more, then we have to consider enema or disimpaction. And please keep in mind at any point of time, you wouldn't want your patients to not have passed stools for more than 5 days. That can lead to paralytic ileus, which is a life-threatening emergency. So while you are trying all of these protocols, ensure that you have a good liaison unit and liaison with a gastroenterologist or a general surgeon if a gastroenterologist is not available, so that they can help with the enema or disimpaction in a timely manner. There are newer drugs that are coming up in the treatment of constipation. They include intestinal secretagogues like lubiprostone, which is a PGE1 analog, linaclotide, which is a guanylate cyclase C agonist, and plecanatide, which is also the same, which has the same mechanism of action. But the last two are not available at this point of time commonly for the treatment and has to be perhaps used with the liaison with the gastroenterologist. When ileus does happen, how do you recognize it? You recognize it by the following signs and symptoms. If the patient has moderate or severe abdominal pain or discomfort that is lasting for 1 hour or more, along with it, if they have either, not all, either vomiting, especially if it is a feculent vomitus, abdominal distension, absent bowel sounds or high-pitched bowel sounds, bloody diarrhea, or hemodynamic instability or signs of sepsis, then it means that the patient has developed paralytic ileus and we need to immediately refer them for emergency surgery management. Next, coming to sedation. Sedation is also one of those common adverse effects, which is common in the first few months, but unlike constipation, it usually decreases with time. I say usually because in some rare cases it may persist. The mechanism of action of sedation, mechanism of action of how clozapine causes sedation is very, very straightforward. It is through the histaminergic blockade and through the muscarinic blockade. I've already told you that it is perhaps one of the commonest adverse effects of clozapine, as high as in every second patient. And when it is there and it has become very problematic, in which the patient is saying that, well, doctor, if you are not going to address this sedation, I might have to actually reconsider my consent for clozapine, at which point of time you might have to try one of the two strategies. Either you reduce the dose by about 5% every 4 weeks, or give a smaller dose in the morning, preferably push the dosing to the night, especially if they're working during the daytime, so that the sedation doesn't impact their daily livelihoods. If despite all of these strategies, sedation is still a concern, then you can consider the use of drugs like modafinil, very low dose aripiprazole, or one unique molecule called as betahistine, which we generally use in vertigo, but it has a role in promoting alertness, and it also has a role in promoting wakefulness during the daytime when associated with clozapine. Betahistine, incidentally, also has a role in suppressing the appetite. It is not very, very surprising, because when you think the last time that you took citrazine or any other antihistaminergic molecule, all of you might have felt a sort of increased appetite and a tendency to actually want more carbohydrates. So betahistine, acting as an inverse agonist, obviously is more than likely to reduce the appetite also and improve alertness also. But a word of caution, we have reported this from our center in literature as well. Betahistine also is slightly pro-inflammatory. Not surprising, isn't it? If citrazine and antihistaminergics are anti-inflammatory, betahistine is slightly pro-inflammatory. And when that happens, we have to actually be aware that the tendency for any immune response being mounted to clozapine and any adverse effects of clozapine which can have an immune component might be higher. But more on that later. The next side effect that we are going to discuss is regarding the orthostatic hypotension and syncope. The onset is usually within a couple of weeks, but it decreases with time, with patients actually developing a tolerance to it over 6-week duration. So this is one side effect which is very, very common during the acute phase, but there is a tendency for the bodily homeostatic systems to adjust over the coming 2 to 3 months, wherein the patient actually overcomes orthostatic hypotension. The mechanism of orthostatic hypotension and syncope is straightforward. It is through the alpha-1 adrenergic antagonism, and first line strategy and intervention is usually through psychoeducation, warning them beforehand, especially if they are more than 45 years of age, that there is likelihood of syncope and orthostatic hypotension. So they have to be reassured that if that happens, that it will improve over time, and they need to be counseled to rise up slowly, especially from a lying down position or a seated position. They have to be warned about the seriousness of falls, especially if they are the elderly population, because falls can have inadvertent other risks, including fracture of the femur, a radial fracture, or other serious head injury consequences, which can become very, very problematic. We also can encourage them to have adequate fluid intake to prevent dehydration, which may actually worsen the orthostasis. With respect to the pharmacological management, one way is through a slower up titration, not rapidly increasing the dose. We also have to see if they are concurrently on other antihypertensives and see if we can reduce the dose of the other antihypertensives that they are concurrently on. And if nothing works, lifestyle interventions, intake of water, and all these positive measures that we discussed in the previous slide doesn't work, we can consider fludrocortisone 0.1 mg per day in combination with a slightly increased salt diet temporarily, so that the risk of falls is mitigated. Mind you, this is a temporary strategy and not meant to be used as a long-term or a permanent strategy. If the patient, even after 6 to 8 weeks, continuously develops a syncopal attacks, continuously has orthostatic hypotension, this is called as a malignant syncope, other causes has been ruled out, then termination becomes our last strategy. Next side effect is tachycardia. It is usually seen in the first 4 weeks, but it rarely might persist beyond that, usually self-limiting. It is also mediated through the alpha-1 adrenergic blockade. When it comes to the treatment of tachycardia, I want to highlight that tachycardia itself, prolonged tachycardia itself, can risk the chances of a myocarditis. Therefore, please do not neglect persistent tachycardia in your patients. If you find your patient is having the heart rate consistently between 110, 120, and you're thinking, well, it's just tachycardia, it's not as simple as that. We need to be mindful that persistent tachycardia over many months and years can cause cardiomyopathy. So we have to take it seriously. We also have to keep in mind, and this is why I've highlighted it in red, that a new onset tachycardia in the second or a third week could be the earliest marker of a myocarditis. So if the patient was not having tachycardia on the lower doses, suddenly by about third or the fourth week starts developing tachycardia, please keep in mind, this might be the first warning that it is a myocarditis that is setting in. Treatment-wise, it is relatively straightforward. We initially consider beta blockers, although they are not a long-term treatment strategy. And if it doesn't work, then we consider ivabradine 5 to 10 milligrams per day. When patients come to us with tachycardia, as I said, we need to first ask whether it is due to orthostasis, and we need to understand whether it is in the acute phase or the maintenance phase. Have we ruled out myocarditis? Are there any other anticholinergic or adrenergic medicines that are co-prescribed which can be tapered off and stopped? Is there an evidence for an infection or an inflammation that could be causing the tachycardia? And if all of them are negative, only then will we consider instituting long-term treatment with beta antagonists for the treatment of persistent tachycardia. Next side effect is hypersalivation. Hypersalivation is perhaps again one of the most common adverse effects. It is common more so in the first few months. It also decreases with time, although nocturnal hypersalivation tends to persist. Daytime hypersalivation patients tend to report lesser and lesser as the time progresses. The mechanism by which clozapine causes hypersalivation is through the muscarinic M1 and M4 agonism, especially mediated by the norclozapine, which is the metabolite of clozapine. Also through the alpha-2 adrenergic antagonism and an inhibition of the swallowing reflex. So it is actually a multimodal way in which hypersalivation is mediated. With respect to the management strategies, we use rating scales such as the drooling severity and frequency scale or the nocturnal hypersalivation rating scale that is issued with the NHS. We initially try non-pharmacological strategies and lifestyle intervention. And if that doesn't work, then we go to locally acting anticholinergics. And if that also doesn't work, sometimes we use systemic anticholinergics. Although the concurrent use of systemic anticholinergics should be avoided. Nowadays, I see in Indian literature and also in international literature that people have recommended the repurposing of atropine eye drops, wherein they are talking about mixing 1 or 2 eye drops and diluting it and using it locally sublingually for the control of the hypersalivation. Please keep in mind that there has been case fatalities reported in Australia wherein the intake of the atropine eye drops inadvertently in higher doses has led to cardiac morbidity and even death. So Australia has actually issued an advisory saying, well, atropine eye drops should not be used for this purpose. Please use other agents. So it's a word of caution that I'm highlighting at this point of time. Second line interventions include amisulpride and clonidine. Amisulpride incidentally has other gut stabilizing properties, and which is not surprising why it is also used in patients with irritable bowel syndrome more than amisulpride, levosulpride rather. But it is useful in clozapine-induced hypersalivation, especially when first-line agents fail. And as I talked about, systemic anticholinergics can be tried. And if they don't work, then third-line interventions like amitriptyline can be tried as well. Botulinum toxin to the salivary glands in refractory hypersalivation has been used, especially if there is an inhibition of the swallowing reflex or if the patient has a very severe obstructive sleep apnea with the risk of nocturnal apneas. In such cases, very obese patients, they have respiratory difficulties, we can consider them. But I must confess, we haven't been using this strategy for any one of our patients till date, and it has only been reported in scientific literature. So we have discussed about this. Next, seizures. It is not an uncommon side effect. Now, I have actually put it's a common adverse effect. When I say it's a common adverse effect, I don't mean to say it's as common as hypersalivation or as common as tachycardia or postural hypotension. I am actually put it as a common adverse effects to indicate that it is not so uncommon, because the cumulative incidence of seizures is about 5% per year. When you look at 5% per year, that is 1 in 20 patients. So therefore, knowledge about the risk of seizures and how we manage it becomes very, very important. Low dose uptitration and high dose maintenance is something that is to be kept in mind. When we use the clozapine in lower doses during the uptitration, we have noticed that there is a dose-independent risk for seizures. Whereas when used at a high dose during maintenance, there is a dose-dependent adverse effect. So whenever somebody asks you whether seizures is a dose-dependent adverse effect, of course it is. So that's your first straightforward answer. But during uptitration, it could be a silent risk which can go unnoticed. So be very careful about the risk of seizures. And I put a question mark over here because people really to date have not been able to conclusively establish the mechanism by which seizures are caused. There's a lot of hypotheses that are there. You can go up and read about it, but conclusively, nobody has yet established why clozapine induces the risk of seizures. Some people have recommended that to mitigate the risk of seizures, that one uses EEG abnormalities. They do an EEG at the baseline and they look at EEG abnormalities over a course of clozapine. However, people have often actually studied this particular phenomenon and reported that EEG abnormalities are concurrent with the increasing dose of clozapine, but not rather the risk of seizures. Meaning to say, somebody might have a normal EEG, but still be at a risk for seizures, and somebody might have an abnormal EEG, still be at a risk of lower seizures. Therefore, routine EEG is not recommended as a standard practice in the vigilance for the risk of seizures. The other important thing to know is while clozapine can cause varieties of seizures, GTCS seizures are perhaps the most common. Myoclonic seizures are perhaps myoclonic jerks, what we know as myoclonic seizures, are the second most common. Atonic seizures are the third most common, but there has also been incidents of complex partial seizures, including some which we have reported from our center. So clozapine can cause a variety of types of seizures. Please don't be under this misinformation that it only causes GTCS. No, it can, in fact, myoclonic jerks can precede the GTCS also. And then it can cause GTCS more commonly, but other varieties of seizures are also more common. So what do? When we see that a patient developed seizures, first thing we need to ask is whether it happened when we escalated a dose. If the answer is yes, then we send for a serum level and go to the previously tolerated dose. If the answer is no, then we need to understand, is it a pharmacokinetic interaction I'm missing? We will check with them whether there was any other drug that they took concurrently. We will send a serum level, withhold the clozapine for a few hours, and also check for the renal and hepatic function. And if they turn out to be normal, we reduce the dose by about 25%, and we rule out concurrent withdrawal symptoms due to either alcohol or benzodiazepines. And if they are also ruled out, then we go towards the previously tolerated dose. And despite all this, if the patient continues to be at a high risk for seizures or manifest seizures, only then we add the divalproex. Okay, so we don't, at the first sign of seizures, we don't say, okay, let's go and add divalproate sodium for this particular patient. We need to follow an algorithm, right? Next, coming to myocarditis. The mechanism by which clozapine causes myocarditis is it's a cytokine-induced hypersensitivity reaction. It occurs more commonly during the first 6 weeks. It's an uncommon side effect. It manifests in about 3% of the patients. Initially, they have very non-specific symptoms like the malaise, flu, chest pain, fever. Especially, they are actually developing this at, say, critically between 3 to 4 weeks. We need to keep in mind that although CRP is predictive, CRP is more so predictive if we have pre-clozapine CRP and weekly CRP measures. Therefore, you will find increasingly that people will talk about doing serial C-reactive protein levels on a weekly basis for all your patients. What is far more better is troponin levels and echocardiogram. These two are much more sensitive to detect myocarditis. If the patient is having flu-like symptoms, chest pain, fever, myalgia, in addition to suspecting myocarditis, please also keep in mind patients can develop interstitial nephritis. This could be masquerading as a flu-like symptom. So just because you ruled out myocarditis, don't think that, okay, this is due to some other obscure cause like some COVID variant or some other acute respiratory infection that is going on. Please rule out interstitial nephritis as well. And because in the initial 8 to 12 weeks, patients can develop potentially life-threatening complication called DRESS. And we have also reported about DRESS in one of our patients as a case report and how we were able to mitigate it by rigid monitoring in the initial few weeks. If the myocarditis occurs after a long treatment, often the culprit is not a hypersensitivity response, but rather a cardiomyopathy that might have developed, and we need to liaison with cardiology services in order to adequately treat the same. As I said, how do we suspect and treat myocarditis? If in the initial 2 to 3 weeks, there is an increase in the heart rate by about 10 to 20 counts, especially in the initial phase. They haven't manifested a tachycardia, but at the 3rd week, they're developing the same. If there is concurrent constitutional symptoms that has developed, if CRP is rising to greater than, C-reactive protein is rising to greater than 50 milligrams per liter, and if troponin turns out to be positive, or there is left ventricular impairment on echocardiogram, immediately stop the clozapine. And then you will see that within a week, you can actually see the reversal of the myocarditis, and you can consider alternative treatment for the patient. Next, coming to interstitial nephritis, it is also a cytokine-induced hypersensitivity response. It happens like myocarditis in the initial 2 months of treatment. If you're seeing that you're starting a patient on clozapine, and in the initial few weeks, they're developing a fever, which is one of the most common manifestations of interstitial nephritis. And if they manifest proteinuria, you have to be very, very careful that this could be interstitial nephritis. Why is it important to understand this? Because if untreated, if undetected, it could lead to being untreated. And if untreated, that it could lead to chronic interstitial nephritis and long-term kidney damage as well. Nocturnal enuresis is also an adverse effect that is associated with clozapine, but people have reported that it could be due to the schizophrenia itself or as a consequence of the sedation. It is seen more so in the early phase and less in the maintenance phase. Initially, we recommend that the patient induces lifestyle changes in the form of cutting down the water intake during the latter part of the day. And if it is happening also during the daytime, we need to rule out an overactive bladder, and we need to liaison with the urogynecologist or a urologist and see if there is a need for urodynamic testing to treat the patients who are having enuresis. With respect to the non-pharmacological interventions, we need to reduce the fluid intake in the evenings, avoid or ideally stop the nocturnal consumption of caffeine and alcohol, stop smoking as well, consider weight loss regimens, and see if there is any other antipsychotics or other medications that are causing and address the same. We need to also ensure that we treat constipation adequately. And despite all of these things, if still the patient is having nocturnal enuresis, then we consider alternative modalities such as desmopressin nasal spray, 10 to 20 micrograms in the night. But keep in mind that it could cause SIADH. And so we need to be very, very careful about the same. So if it is contraindicated because either the patient has hyponatremia or it is contraindicated because the patient cannot afford it or due to some other cause, then we can consider a trial of a bladder-specific anticholinergic agent like oxybutynin up to 5 mg 3 times a day. We need to monitor, although it is slightly more bladder-specific, they can have anticholinergic symptoms. And there has been some anecdotal evidence that aripiprazole augmentation can help as well, although the mechanism by which it helps in nocturnal enuresis is unknown. Venous thromboembolism is also an possible adverse effect due to clozapine. Although it might not be directly occurring due to the use of clozapine, you have to keep in mind that concurrent smoking, obesity, a sedentary lifestyle might be the contributing factors. The reason why I have put it out here is because it can lead to sudden thrombotic events and vascular events and even death. And therefore, we need to be aware of this particular interaction. Although you see that the risk of venous thromboembolism overlaps when you compare the risks of clozapine-induced venous thromboembolism with other antipsychotic-induced venous thromboembolism, clozapine is especially something that we need to be vigilant about because the risks are that the patient might put on more and more weight, they might become more and more sedentary, and therefore there is a concurrent additional allostatic load that is being added on the vascular system and which can predispose to vascular events. Next, coming to one of the important adverse effects, which is perhaps common and it is sort of manifests in a slow manner, but has a polymorphic morbidity, and that is the metabolic adverse effects. So what is the mechanism by which clozapine-induced metabolic adverse effects occur? It is through the 5-HT2C antagonism, it's through the H1 antagonism, the M3 antagonism, and the D2-5-HT1A and the alpha-2 modulatory properties as well. Now, it is important to note that among these 4 reported effects, it is the first 3 that are more consistently reported as a cause for both diabetes mellitus and the metabolic side effects. The risk for metabolic syndrome in schizophrenia is already higher. This is established very well through epidemiological studies, wherein people have said that overall, if the patient is not treated with antipsychotics, also they are likely to have metabolic syndrome. But if you compare that baseline risk and the general population risk with antipsychotic induced metabolic syndrome, there is perhaps a fourfold increased risk. So 1 in 3 patients that you treat with clozapine is likely to have a metabolic syndrome. And you know that metabolic syndrome has an increased risk of mortality, and it contributes to about 50% of the mortality in schizophrenia. That means to say every second person with schizophrenia who dies will have a contributory element from the metabolic syndrome. Now, whether clozapine caused the metabolic syndrome or was in the contributory pathway, you need to be aware of the same, but you need to ensure that you adequately recognize it and treat it. According to the different studies that have been conducted, the risk of metabolic syndrome is perhaps most universal of all. It doesn't matter which country the patient is from, which gender they are from, which setting the patient is being treated with, they actually continue to manifest metabolic syndrome. Clozapine, as you see, according to the Lloyd meta-analysis, is carries one of the highest risk for the metabolic syndrome. Of course, anecdotal and retrospective chart review seems to suggest that the risk of metabolic syndrome might be slightly more higher with drugs like olanzapine, but clozapine is something that mandates us to be very vigilant about the risk of diabetes and new onset metabolic syndrome. How do you treat? Once we recognize the metabolic syndrome, we target 10% weight loss through adaptive lifestyle interventions, which includes caloric restriction, regular exercise, behavioral modifications. And how do we give this particular adaptive advice? We say that you regard physical activity as a vital sign. Every time that the patient comes to you, don't just record their pulse, BP, temperature, so on and so forth. Also add, are they actually having regular physical activity? How do you define that? You operationalize it by saying if they're at least having 150 minutes per week of moderate aerobic physical activity. How do you operationalize aerobic physical activity for your patients? Because they might not be well aware of what it means. You operationalize it by saying that this physical activity should be something that causes you to puff and pant, right? And it should be for 150 minutes per week at least. Or you recommend 75 minutes of high intensity, vigorous physical activity, wherein the person cannot even talk. They run out of breath, and it can be through vigorous activities such as running fast. I don't personally recommend this strategy in the post-COVID era. So the targeting moderately aerobic physical activity is something that is safe and reasonable. Non-pharmacological interventions, we need to have atherogenic diet goals, which includes reducing the intake of saturated fats, trans fats, and cholesterol. Just saying this doesn't make any difference to our patients. We need to tell them that you need to avoid bakery products, you need to avoid maida, you need to avoid flours and carbohydrate-based diet, and you need to also restrict anything that comes out of a packet or a can. This is sort of a simplistic advice that has helped majority of our patients who might not actually know what saturated fat, unsaturated fat means. Other thing we recommend definitely is the cessation of smoking. We recommend a near total cessation of smoking because the risk of vascular adverse effects with comorbid smoking and metabolic syndrome is very, very high. What are the pharmacological treatment strategies in addition to lifestyle monitoring and monitoring for the risk of diabetes? We consider initial agents such as aripiprazole and metformin, although we consider them only after a trial of adaptive lifestyle modifications. And despite all of them, if the patient continues to actually have metabolic syndrome, then we can consider these molecules. In aripiprazole, there is supportive evidence from 3 randomized controlled trials and meta-analytic evidence as well. It leads to a modest mean weight loss of around 2 kgs or so. And adding aripiprazole to clozapine not only augments its antipsychotic efficacy, it also leads to decreased risk of subsequent metabolic syndrome as well. Okay. In addition to aripiprazole, ziprasidone also has a very, very good role in its efficacy. The only reason I have not mentioned here is ziprasidone is not concurrently commonly used, and there is less limited real-world data about whether it actually leads to improvement in metabolic syndrome. Metformin is one of the first-line strategies. In fact, I would rather rate metformin as my first strategy before aripiprazole even. But if there are concurrent positive psychotic symptoms, then I would consider aripiprazole. But when we use metformin, we should ensure that we use it in the doses of 1000 to 1500 milligrams per day. The question that most postgraduate psychiatry postgraduates ask me is, "Sir, the patient doesn't have diabetes. You're still writing them metformin. Are you sure you want to do that?" And we need to calmly reassure them and say yes, because metformin is not just an anti-diabetic, but it is also a molecule that is very useful in metabolic syndrome and obesity. It has a significant risk of reduction of weight, and also the way improves the waist hip ratio. It also improves the fasting glucose, and it doesn't carry a huge risk of hypoglycemia. In fact, the risk of hypoglycemia is much higher in sulfonylureas and other oral anti-diabetic agents. It also improves other parameters such as the lipid profile. The only adverse effects that you need to be aware of is it can lead to gastrointestinal disturbances. And one practical tip that I want to give to all of you is Indians are generally very worried about the flatulence and gastric irritation. So you need to inform them that metformin can cause that, but that can be managed through other probiotic measures and other healthy intake of fibers, and they need not stop metformin just because they develop flatulence. The last point about metformin is that it can lead to vitamin B12 deficiency, and so you need to be aware of supplementing B12, especially if the patients are vegetarians. Topiramate also has a role in the treatment of metabolic syndrome. It might in fact have an additional role in the improvement of psychopathology, although there have been some evidence of worsening of hallucinations as well with topiramate. But if the patient has significant weight gain, also concurrent issues like migraine, lot of appetite, then I would certainly consider topiramate as one of the augmentation strategies. It can lead to modest decrease in weight up to 3 kgs, and paresthesias and other adverse effects is something that can be managed conservatively. Beta histine is something that I've already highlighted earlier, but people have used it in doses as high as 144 milligrams. Just imagine, this is not the 16 mg Vertin that we are using. People have used in very, very high doses. But I am not personally in favor of using such high doses, because we in our center have reported a case wherein we use beta histine for the control of acute sedation and acute weight gain, and it actually led to an increased risk of early myocarditis, which we then were able to detect early and treat promptly. So if the patient is complaining of resistant metabolic syndrome and daytime sort of sedation, which is not getting better with time, then you could consider low dose beta histine as a strategy. But keep in mind the risk of inflammatory adverse effects, especially in the early phase. There is also good RCT evidence in favor of fenfluramine, reboxetine beta histine combination, zonisamide, and phentermine and topiramate combinations, although the real world use and real world evidence is very low regarding these molecules. There have been other molecules that have been tried as well, but again, real world data about them is very minimal. One thing that I want to talk about with respect to the emerging evidence is with respect to the importance of GLP-1 analogs. I personally wouldn't recommend the use of naltrexone and bupropion as a first-line strategy because of the clozapine's risks for seizures. And if you concurrently use bupropion, there is an even higher risk of seizures, and I'm personally not in favor of the same. But however, it has been reported in literature. But what is important among the newer drugs, and this is something that I want the psychiatry postgraduates to be very mindful of, is the early initiation of glucagon-like peptide agonists for weight management in antipsychotic-induced weight gain. This is becoming more and more mainstream. In fact, as recently as, last month, in the Lancet Psychiatry, the latest guidelines for schizophrenia, called as the Integrate Guidelines, was released. This particular guidelines highlights the importance of early metabolic syndrome risk screening and early institution of GLP-1 agonists so that the risk of metabolic syndrome and subsequent weight gain and diabetes is mitigated. So please keep in mind, psychiatry postgraduates and psychiatrists, that we can use this molecule, of course, concurrently liaising with our endocrinology colleagues. Among the GLP-1 analogs that are available in the Indian markets, exenatide and liraglutide have been there for quite some time now, and they have shown its results. Please don't go by the fame that Ozempic is receiving in the American population. We don't know about the safety of Ozempic yet in clozapine and antipsychotic-induced weight gain and metabolic syndrome. We just need some more real-world data. Better to start with other established molecules like liraglutide before we try Ozempic or other strategies. Bariatric surgery works when nothing else works and when all other treatments for metabolic syndrome has failed, wherein if the patient especially has had concurrent comorbidities in the form of vascular comorbidities, cardiac comorbidities, and they have pathological obesity, severe obesity, then we need to consider bariatric surgeries. We need to keep in mind that bariatric surgeries are not something that we will recommend firsthand. In fact, it is something that we will recommend when all our first line, second line, third line interventions fail, because the complication rates can be as high as 1 in 5. And there is also a risk of reoperation of around 1 in, say, 11 or 1 in 12. So therefore, we need to keep in mind that if everything fails, that we can recommend bariatric surgeries. And among the bariatric surgeries, although gastric bypass is more effective in weight loss, it has more complication. So what could be much more safer is adjustable gastric banding, because it has a lower mortality and complication rates, but the weight loss is not as substantial as a gastric bypass surgery. This also carries a mortality rate, wherein 0.3% of the people can die, and we need to be mindful of the same. Now, with respect to the clozapine-induced OC symptoms, which is also a form of an adverse effects, it has multiple mechanisms have been documented as to how it causes the OC symptoms, with multiple pathways of the CSTC circuits being implicated. But more importantly than that, I need to highlight to all you psychiatry postgraduates that don't just assume it was due to clozapine whenever you see OC symptoms or OCD in a patient with schizophrenia after you've started clozapine. Because epidemiological studies, untreated schizophrenia epidemiological studies, longitudinal catchment area studies shows to us that there are 4 kinds of presentations that OC symptoms can have when it is there concurrently with schizophrenia. One is wherein they were present much before. So it manifests during the prodromal phase itself, and an OCD is actually there much before, and then later on they manifest full-blown psychosis. It could be intermittent OC that is seen during an acute exacerbations of intermittent psychosis in ATPDs that could be seen, in which case it is self-limiting and we can treat it in an episodic manner. Or it could be seen during the first psychotic break or the second break of psychosis, and it can persist. Or it can have a fluctuating course, more commonly in the schizoaffective disorders, especially with schizodepression, wherein it can go up and it can improve during schizomania states. Or it could be true antipsychotic induced OC symptoms, wherein it is none of the other trajectories. It is clearly after the initiation of clozapine. So one can ask, well, how do you know, sir, that antipsychotic itself has caused the OC symptoms? There is epidemiological studies to suggest that the prevalence rates of OC symptoms in schizophrenia increased after clozapine was approved in the market. The comorbidity rates of OCD with schizophrenia is are higher than at first manifestation of schizophrenia, which means to say it becomes higher with time, which means to say that you treat a patient with antipsychotics and later on they manifest. The patients with comorbid OCS are frequently found to be treated with clozapine or olanzapine than other antipsychotics, and it also shares a dose-response relationship. All of this proves that antipsychotic-induced OC symptoms is a reality, and it is not just something that is an aberration. So what are the statistics of antipsychotic-induced OC symptoms, especially clozapine-induced OC symptoms? They can occur anywhere between 1 in 20 patients to 1 in 3 patients. Males seems to be at a higher risk for this thing, and it seems to have an insidious onset and an association with negative symptoms, and especially in people who have a long period of a prodrome or an attenuated psychosis. And it may be associated with depression and suicidality, especially in schizoaffective disorders. Please keep in mind, presence of an OCD or an OC symptom during the prodrome is not an indicator of a conversion into long-term psychosis or OCD. So it could just be a signal that appears in the prodromal phase as well. Among the symptom dimensions, aggressive OC symptom dimensions, checking and holding symptom dimensions seem to be much more common. So we have talked about the risk. So how do we actually understand it after the clozapine is initiated? It manifests within few weeks to about the first year. It could be there with other antipsychotics also. There have been anecdotal reports of even risperidone causing OC symptom. I have put it out here not because risperidone has a higher risk, But as a paradox, because risperidone is one of the frontline agents that we use for the treatment of augmentation of OCD. Okay. So then we have other mechanisms like 5-HT2A and 5-HT2C receptor antagonism, which play a role. The management principle for antipsychotic induced OC symptoms is slightly different from true OCD. And I will highlight a couple of points that are important over here. The first point is that please treat the psychosis well. Because if you actually treat psychosis well, it is possible that the OC symptoms go away on their own as well. Once you've adequately treated the psychosis, despite that, if OC symptoms and OCD persist, then you can consider low-dose aripiprazole, low-dose risperidone, memantine, which is also an augmentation strategy for resistant schizophrenia, and neuromodulation. Among the neuromodulation, you would perhaps choose weak intensity neuromodulation like TDCS over stronger intensity neuromodulation like RTMS or deep TMS because of the concurrent risk of an increased risk for seizures. There is evidence to suggest that ziprasidone might be more beneficial, but these are anecdotal evidence. So despite all this, despite adequately treating the psychotic symptoms with antipsychotics, and despite adding aripiprazole, risperidone, memantine, or trying neuromodulation, if still the patient is having significant OC symptoms, we of course initiate SSRIs. Among SSRIs, we choose escitalopram or sertraline, which have less drug-drug interactions. There is also some evidence to suggest that we can change over to another antipsychotic if it becomes very, very, very severe. But in real-world practice, if a patient has responded to clozapine and developed clozapine-induced OC symptoms, we would not actually let go of the clozapine, but rather we would effectively treat the OC symptoms instead. There is some level 3 evidence for the use of clomipramine, fluoxamine, and other SSRIs. This is poor real-world data, and I wouldn't recommend the use of the same because of the concurrent risk of seizures, concurrent risk of anticholinergic side effects, concurrent significant pharmacokinetic interactions. So please don't use them. They have been reported, but don't use them. Don't also mention them in the examination as first-line strategies. If everything fails, then you can consider them. I would rather think out of the box and treat the patient with mood stabilizers, especially if there is a schizoaffective kind of a trajectory. And lamotrigine as an augmentation strategy for OCD also has a moderate effect size, and therefore it can be considered as well. Psychotherapy has poor evidence, especially because the cooperativeness with respect to the ERP, the success rates with respect to the ERP might be lesser as compared to the pure OCD cohort. However, people have reported, although they might not remit, improvement per se, that is defined as reduction in the severity scores, might be seen in majority of the people. Now, if it is clozapine-induced true OC symptoms, and you have tried many strategies, it's not working. First, you try to reduce the dose, you try to rule out other drug interactions, and consider the strategies that I have highlighted. The last part of my talk is focused on agranulocytosis, and I'll be finishing within maybe about 2 to 3 more minutes. The agranulocytosis risk is something that has multiple modalities by which clozapine can cause the same, in which antibodies against myeloperoxidase is one mechanism. The clozapine oxidized to a nitranium ion inside the neutrophils and triggering an immune response is another mechanism. A hapten-based mechanism in which the neutrophils are activated and the immune response against the haptenized neutrophils is also regarded as a mechanism. A direct toxicity of clozapine on the bone marrow stroma has also been implicated, and histamine 4 receptor mediated immune dysfunction also has been reported. So there are many ways in which clozapine can cause neutropenia and agranulocytosis. We've talked about the Finnish Amsler study. Fundamental concepts that you need to be aware of when it comes to clozapine-induced agranulocytosis is, number one, that clozapine is associated with neutropenia and not leukopenia. So it's not that all the cell lineages among the white blood cells goes down. It is specific to neutropenia. We need to be also aware of this entity called as benign ethnic neutropenia. And we also need to be aware that if a patient is concurrently on valproate, especially during the initiation phase, there might be a heightened risk of agranulocytosis. This is also something that we have reported in literature. And the risk of clozapine-induced agranulocytosis after 1 year of treatment goes down drastically. Now, this is something that you increasingly will hear about, and I will highlight about this. The risk of clozapine-induced agranulocytosis, true agranulocytosis, is 0.8% at 1 year. Now, I'm not talking about the incidence of neutropenia. That is at a much higher 2 to 3%. You need to understand neutropenia can be transient. Neutropenia could be due to benign ethnic neutropenia. But true agranulocytosis is at a 0.8% risk at 1 year. Death due to neutropenia is very, very, very rare. It is about 1 per 7,700 people exposed to clozapine. That puts it at a 0.0013%. Now, why did I put it up there? I put the statistic up there to highlight how other important adverse effects like an orthostatic hypotension and a fall, myocarditis, paralytic ileus, all of this can actually sort venous thromboembolism, metabolic syndrome. All of these are likely to kill the patient who is on clozapine and concurrently having schizophrenia by a myriad of other lifestyle factors than actually true agranulocytosis. So we have to be still vigilant because this is something that could turn lethal if it is not recognized. The risk is very high as compared to the later stages. I'm not saying the risk of agranulocytosis is very high. I'm saying if at all you were to stratify the risk of true neutropenia and true agranulocytosis, the risk actually aggregates more in the first 18 weeks. It goes down with time, and after 1 year of treatment, you will be surprised to know that the risk of clozapine-induced agranulocytosis is the same as chlorpromazine-induced agranulocytosis. Do we actually do regular blood monitorings on a monthly level for patients on long-term chlorpromazine, long-term olanzapine? We don't, isn't it? We do once in 3 to 6 months. And therefore, there has been an increased voice in the scientific fora, increased number of publications, increased demands for reduction in the intensity of blood monitoring, especially after 1 year. People say, okay, monitor. Yes, the risk is high in the first 18 weeks. You go as per the Maudsley monitoring regimen. But after about a year, we really need this particular monitoring schedule to be so active is something people are questioning. There is one more reason why people question this arbitrary monthly for life kind of a strategy. You know why? Because let's say you check the blood of a patient on 5th of June and it turned out to be normal. And the patient starts developing agranulocytosis on 6th, 7th, 8th of June. Then by the time you do the next blood monitoring, the patient has already gone into septicemia shock and has passed away, despite sticking to the so-called treatment regimen. So therefore, people are increasingly calling to caution and saying that, well, what is this 1 month business that people are talking about? But for the purposes of the examination, don't be foolhardy in mentioning that we will suspend any sort of a risk evaluation and mitigation strategies. But be aware of this because it's an emerging talk. Some people say, do we treat it with lithium? Because lithium can help deal with the mood symptoms and it can help raise the number of leukocytes. Yes, it does raise the WBC count acutely and chronically. And the mean rise is almost up to around 2000 WBCs per millimeter cube. And you need a minimum of around 0.4 millimole per liter of lithium levels to produce this kind of an protective response in to prevent agranulocytosis. But please keep this in mind. This is a form of hoodwinking the body, hoodwinking the immune system. I call it as a hoodwinking the immune system because there is a GM-CSF stimulation that is happening and a demargination, which means to say that the WBCs are demarginated and released into the bloodstream. Therefore, you're actually getting a fake higher count. I call it as fake higher count because you're depleting the stores. You're depleting the bone marrow reserves. So do not be under this false assumption that, well, there was some neutropenia and I gave lithium, it is stabilized and I need to be now relaxed about it. No, please continue to monitor because if demargination and GM-CSF mediated effects are there, then the pool might come down with time and the patient might go back into neutropenia and agranulocytosis. We need to also keep in mind that lithium can also help in non-clozapine related neutropenia, especially if it is happening due to other causes. GCSF can be used if it is happening, it is persistent, and we cannot give any other antipsychotic to the patient, especially if they have responded very well. So in liaison with the physician, we can consider using the coronary stimulating factors, but you have to keep in mind that it can mask impending neutropenia or agranulocytosis by the mechanism I just described. But you also need to keep in mind that it can cause some bone pain and neutrophil dysplasia and increase the risk of long-term malignancy if it is used for a long period of time. And we usually give a test dose of 300 microgram subcutaneously before we use GCSF. And thrice weekly doses might be necessary for a period of time before the patient is stabilized with respect to the WBC. If there is severe neutropenia, as defined by lesser than 500 per millimeter cube, it carries a higher fatality rate of 2.1%. Even after you stop clozapine, it can last for about 12 to 21 days. So you need to ensure that you admit the patient in a sterile ward, give antibiotic prophylaxis, give coronary stimulating factors, and treat them in an ICU setting along with the liaison with the intensivist and emergency physicians. There is some evidence to suggest that the monitoring of clozapine might become easier with time with the FDA approval of point of care monitoring devices. These devices work through the digital mode in which they actually check the blood, and then you have an app which can give you your values about the neutrophils. So therefore it reduces the risk of going to the hospital, right? So these are some developments that has happened in the area. When do we not re-challenge the patients? When they are taking clozapine and they have developed agranulocytosis or severe neutropenia. If the blood levels have fallen below 2000 per millimeter cube, or if the neutrophil count has fallen below 1000 per millimeter cube, then in such cases, we do not do it. And if the fall has been very drastic, the absolute counts might not have fallen so much, but the fall has been very drastic, then we can actually consider it as a contraindication to a rechallenge. Or if they develop severe neutropenia or prolonged neutropenia, they are also contraindications for a rechallenge. Now, on this note, I would like to end today's talk. I have very many slides to present, but however, I know that we have exceeded time, and for the sake of the brevity of time, and for the sake of the organizers who have actually requested us to wind up within 1.5 hours, I will stop my presentation over here. And hopefully the next phase of this particular talk can be held in an alternative fora, where I'll be happy to share our therapeutic drug monitoring services, pharmacokinetic interactions, and what we have learned about the same from our center, with other evidences from our center with respect to a robust clozapine response that we have been seeing as compared to the Caucasian population, and how Caucasians need higher doses of clozapine to achieve the blood levels compared to Indians and Asians. Through our center and our published literature, we know that Indians might actually require lower doses to achieve therapeutic drug levels. These are things that I would like to address in a subsequent class when I am given an opportunity to do so. I thank the organizers once again, and I hand the fora back to the chairperson. Sir, over to you.
Thank you, sir. It was really a lucid and extensive lecture on the clozapine. Definitely many things you have discussed. Actually, whenever we write clozapine, we think mostly about the agranulocytosis, the occurrence of which is not that much. It is very much, it is in the lesser part. But other like constipation, other things is a huge risk in this clozapine. And I'm sure that the participant of this webinar, many of us, we had a refreshing memory of the whole theoretical aspect of clozapine. Because one of the problems comes, we need to minimize the side effects, or just we don't go deep into the things, and especially the myocarditis. What are the early signs of myocarditis? And these are the very important things you have told. And really, it was a very, very nice to listen to you. And means what to say that of course it is a one drug that which gives the much more benefits to the patients. But now after your lecture, we got to know that actually there is not much. We should not be that much afraid of writing this clozapine, but we need to be very much vigilant at least for initial 3 to 4 months about the side effect profile. That is the one of the safest way, because whenever we have seen that schizophrenia and other psychotic disorders actually because due to now patient parties also, they are very much restless, they are running here and there, and whenever the patient comes, maybe after 1 or 2 years, he already visited many psychiatrists, and in those cases we find that actually not all psychiatrists they have gone up to the optimal level with their either atypical or typical antipsychotics. So these are the things actually we need to think about it. We can take the patient and we can give a fresh trial for 4 to 6 weeks with the maximum therapeutic dose of any molecule that has been applied. And after that one, we can start Clozapine. And in my clinical experience also, we are using definitely everyone, the faculty members who are present here, they are writing extensively. And we have seen that Clozapine is such a molecule that even in my clinical practice, I did not find that even a single patient that it did not help. But in some cases, I had to stop Clozapine due to some adverse effects, even after trying to manage in many ways. So these are the things, but I think Clozapine till now, it is a gold standard. There is no doubt about it. And the risk profile can be evaluated very easily if we are vigilant. And we must know all the side effects, minor and the major one, that you have depicted in your slides. If it clicks to our mind that what the patient is complaining, maybe a little bit heaviness or the chest tightness or whatever the things, we should click to our side effect profile. Otherwise, we'll just ignore the side effect profile, as you have said, that okay, simple tachycardia, simple tightness of the chest, constipation, let it be. We don't go deep into that. So my message from my to everyone who are the listeners here, actually, it should be that we need to take care of the words uttered by the patient in respect of the side effect profile. And till now, this is a magic molecule, I'd rather say, because I have seen in clinical practice, it helped so many patients in such a way that even after 2 to 3 years, if the patient goes to the higher centers, they don't find anything in the patient, and they're writing, really, did you have any psychotic symptoms at the initial phase? So I think it was a very good lecture, and just not to know the benefits of Clozapine, but we need to be very much vigilant what may be the problems. So I cannot find actually much questions in the chat box, but some Dr. R. Krishnan, he actually asked he cited one actually one article which told that there is some, even after they compared with the other antipsychotics, atypical antipsychotics, but Clozapine did not show much more beneficial to other antipsychotics. I tried to study that, but due to shortage of time, I could not do it. So can you please answer such studies if you have in your mind? That one study actually cited that it was not beneficial in comparison to other molecules of antipsychotics. Few words on that.
So thank you so much, sir, for that kind words, and of course the expert comments that you made about how one needs to be vigilant about Clozapine. Now, regarding this particular study, wherein they have highlighted an individual patient analysis and looked at whether Clozapine is actually superior, they have found out comparable efficacy with other antipsychotics, which means to say that if a patient actually is given Clozapine as compared to other antipsychotics, they seem to have similar sort of an reduction in the scores. But one very important thing that I have found out is that majority of these individual patient meta-analysis and mega-analysis and analysis of RCTs are actually hindered by the fact that the patient selections for that particular RCTs are very, very unreal, in the sense that they don't reflect the real world population. So these are patients who would actually sort of be very, very ideal, only have psychosis for about, or schizophrenia for about 10-year duration, no comorbid depression, no comorbid OCD, no comorbid aggression, no suicidality, no risk of harm to self or others. So these are some of the inclusion criteria that will be there. So when you have such studies there, and when you analyze patients from such cohorts, yes, it is comparable. But when you see the real world data, patients with aggression, patients with suicidality, patients with resistant schizophrenia, patients with a lot of affective symptoms, time and again, it has shown that clozapine continues to be superior. Now, this is despite all the newer drugs that have come to the market. And there are some good ones too. The newer drugs are not bad. They are good ones too. But to date, clozapine remains the most important molecule. But when it comes to analysis of RCT-based evidence and the analysis of published literature, we have to understand it is limited by the inclusion criteria of these studies. So I would take it with a slight pinch of salt.
Thank you, sir. Sir, another question in the chat box actually. The re-challenging should be avoided in which of these side effects?
I would say that, as I highlighted, for me, the immune-mediated side effects in the form of myocarditis, established myocarditis, not just a suspicion of myocarditis, established interstitial nephritis, and a severe agranulocytosis. Now, I'm not even saying that any patient with a neutropenia should not be rechallenged. There are still guidelines to say that patients with a neutropenia who later on stabilized with treatment and vigilance, we can still rechallenge. But these three, I would definitely say that should not be rechallenged with clozapine.
Sir, another question is there, sir, when considering metformin, at what dose we should be vigilant about lactic acidosis?
In my experience with the use of metformin, I'm yet to see a case of lactic acidosis happen, because we recommend doses between 500 to about 1500 milligrams per day. We rarely use it beyond 2 grams per day, although in patients like endocrinologists and others might use higher than that. So we haven't come across incidents of lactic acidosis in our clinical practice. But the other point that I want to make at this point of time, I work in a tertiary care facility where we do not have consultation liaison services. So there is a possibility that patients who develop lactic acidosis or other such complications might be seen in consultation liaison units. So my colleagues who are working in multi-speciality hospitals might be better suited to answer the exact numbers. But in my experience of the past decade, I have not seen a single patient with lactic acidosis thus far on metformin.
Thank you, sir. Sir, I have one question. Actually, in our clinical practice, I found one patient. Actually, patient developed high blood sugar after the initial treatment of about 1.5 years, and the patient was quite all right. But after that one, when the sugar level went high, I tried to change it to other antipsychotics, but ultimately we have seen that in a course of 3 to 4 months it didn't work. So again, I restarted the clozapine, and along with the treatment by diabetologist, he added some molecule. So now the patient is it's stable, and the sugar level also I think around 110, and the PP is around 170, 180. Patient is maintaining well, as well as in terms of diabetes and in terms of psychotic illness also. So my question is that is there any oral anti-hyperglycemic agent that should be avoided with the clozapine, so that I can guide the patient or I can guide my diabetes friend? Is there such any study or anything, sir?
I am not aware of any study that says that a class of anti-diabetic agents should be avoided for use, especially when used with clozapine. However, I am aware of the fact that among the choices, GLP-1 agonists, metformin, and sulfonylureas are safely used. They are something that is safely. When we used metformin, clozapine, and acarbose, then the risk of gastrointestinal adverse effects, worsening of slow transit constipation can be particularly high. So I would be a bit wary about acarbose per se, but all other agents are something that we use. GLP-1 agonists, I'm very optimistic about in the coming years. It has been in the market for about the past decade or so, but in its use for psychosis and schizophrenia per se, as psychiatrists ourselves, I think that day will arrive very soon, sir. In about a year or two, I think we will have psychiatrists prescribing GLP-1 analogs to our patients with schizophrenia and the risk of metabolic syndrome, or for those who have developed diabetes and significant obesity.
Thank you, sir. One last question from my side, actually. So even after giving this clozapine and other oral anti-hypoglycemic agents, so when should we close this or change our clozapine? So shall we wait for some time, or there is some blood sugar level that if it goes beyond that, there is no other chance that we need to close the clozapine? Is there anything in your mind?
So when we treat a patient with clozapine. We have ruled out every other cause for a increase in the blood sugar, that is hyperglycemia. If they develop diabetic ketoacidosis in the absence of an identifiable stressor like a pneumonia or a sepsis or any other secondary cause, and if they are requiring ICU care because of the same, those would be the conditions in which I would be very, very wary of rechallenging with clozapine. And even if I do that, I would do it in a very measured manner, use as low as doses as low as possible with adequate monitoring for the blood glucose on a initially on a weekly basis, then on at least a fortnightly basis, till I'm reasonably certain that the risks of these diabetic severe events are lesser.
Thank you very much, sir. Your slides, I think the participants here, the PG students, I think they would remember for their whole life, because these are the things actually it is not covered in other lectures, and just we are thinking about agranulocytosis, myocarditis, but there are many scopes that we can get maximum benefit of this molecule to our patients. So from my end, I hand over mic to Professor Ashwin, sir.
Thank you so much, sir.
Right, great.
The last point that I would like to make is with respect to the words of my teacher and my mentor, Professor Venkat Subramaniam, who used to always say that clozapine doesn't mean hopeless end. It actually means endless hope. So I want the psychiatry postgraduates to actually have that attitude towards clozapine. Please don't be afraid of this molecule. It actually offers a lot of hope for many of our patients, and we should use it after having obtained knowledge from all of these various sources in a much more confident manner. Thank you, sir. And sorry that I spoke after the chairperson spoke. Over to you,
No,
sir.
Thanks.
Excellent. I could not have thought of a better, end to the talk than the statement that Suhas just made, that, clozapine has always been perceived to be a molecule that is to be the last resort. But there's a lot of literature emerging now which talks about its utility and its benefits of it even being the first line choice in many cases, in many situations, particularly in chronic cases. It's surprising that yet we do see cases who have been drug naive for nearly 10, 15, 20 years of their illness going on. So in that sense, it is still a drug of choice in many patients. And I think Suhas did a fabulous job of enumerating all the mechanisms of the drug and particularly the adverse effect profile. I think awareness about the adverse effect profile is the best antidote to dealing with the adverse effect profile, because the thing is that it has been advocated as a draconian drug for some years until the recent time when we realized that it isn't as bad as it was made out to be. I remember my postgraduate days, which was a few decades back, where it was just about getting relaunched because it had been taken off the shelves for the supposedly draconian agranulocytosis side effect. And we in those days used to monitor the patients very closely, and we found pretty much exactly what Suhas pointed out, that the incidence is so negligible that it's almost non-existent in most patients. In fact, we would see a little bit of a spike in the neutrophil counts in some of the patients who were exposed to clozapine for the first few weeks. So it was a bit of a paradox, and we couldn't really understand what was the hula hoo about. But nonetheless, we live and we learn. And it has been truly a masterclass. The only problem, Suhas, is now you whetted our appetites, and we might want to have you back to share your experiences with clozapine that you pointed out in your discussion today. And we want you to present your data about what are the benefits of clozapine in different situations and what are the mechanisms for that. So you have kind of invited yourself back again, and I hope we will be able to have you back sometime to talk about your experiences with clozapine. But again, I thank you all for being with us today. I particularly thank Dr. Suhas Satish and Dr. Divyan Sarkar for making the time and being with us today, and being a part of this lecture series, which we continue to endeavor to bring to the postgraduate students. And as I see by the number of attendees, we have more and more consultants coming in as well, because if we have good speakers with good topics, then education and curiosity has no bar. So we are having more and more people joining in, and that is a true testament to the quality of speakers that we have, such as the one today. So thank you all very much. And of course, thank you to Sun Pharma for their unflinching support to us all through this entire decade of lecture series that we have. And we promise to bring you interesting lectures going forward as well. And I wish you all a great evening ahead. And thank you for being with us. Thank you.
Thank you, sir.
Thank you, sir.
Thank you.
Thank you.
Thank you.
Thank you, everyone.
Bye, sir.
Bye-bye.